I would like to welcome everyone to today's webinar presentation, Clinical Resilience, Preventing Burnout, Promoting Compassion, and Improving Quality. The Schwartz Center for Compassionate Healthcare is a national nonprofit organization dedicated to strengthening the relationship between patients and their clinical caregivers and preserving the human connection in healthcare. For decades, we have known that empathy improves patient-physician relationships and quality of care, yet we continue to see declines in empathy during training and a lack of compassion when patients need it the most. Research in cognitive, affective, and social neuroscience suggests that developing resilience is one key to sustainable empathy and essential for compassion. In particular, clinicians need to be aware of, monitor, and regulate their own emotional resonance when in the presence of suffering so that they can be cognitively and emotionally available to patients. Recent intervention research suggests that resilience can be promoted and compassion achieved through self-awareness practices, including meditation, narrative, reflective questioning, and appreciative inquiry. These will be described and explored during this webinar. My name is Lynn Osborne, and I'm the Director of Business Development and Operations at the Schwartz Center for Compassionate Healthcare. I'm pleased to be your moderator for today's session. Before we introduce today's speaker, let's go over a few details about the webinar. The Schwartz Center Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 60 minutes. The first 45 minutes will be presentation, followed by a 10-minute question and answer session. Today's program is being recorded and will be available on the Schwartz Center website a week after the session. Please note that attendees are participating in listening-only mode, but can interact with the speaker and me by using the questions pane located in your webinar management toolbar, which should be appearing on the right side of your screen. If you have questions during the session, please just type them into the questions pane and send them to us, and we will address them verbally at the end of the formal program. If time does not allow us to answer all the questions, they will be sent to the speaker, who will do his best to get a response to you directly. We may also be polling the audience during this session, and we hope you will participate in this measurement tool. As you exit the webinar, you will receive an electronic survey that we hope you will take a minute to complete so that we may measure your assessment of today's program. Your feedback is really important to us. Also, for at the start of the actual session, the first 100 folks who came in to register and logged in will have access to our webcam feed, and you'll be able to see our speaker. And now it is my pleasure to introduce our host for today's session, Dr. Beth Lamb. Beth is an Associate Professor of Medicine at Harvard Medical School and the Medical Director of the Schwartz Center for Compassionate Care. Take it away, Beth.
Thank you, Lynn. I am delighted to be here today to introduce today's speaker, Ron Epstein. Dr. Epstein is Professor of Family Medicine, Psychiatry, Oncology, and Nursing at the University of Rochester Medical Center, and he is board certified in Family Medicine and Hospice and Palliative Medicine. In addition to his clinical work, Dr. Epstein is active in research and in medical education. He's the director of the Center for Communication and Disparities Research, which focuses on how to improve communication among clinicians, patients, and their loved ones. He also directs the Dean's Teaching Fellowship Program to promote excellence in medical education. He's published more than 200 scholarly articles, many of which I've read, including his seminal article, Mindful Practice. We're very, very happy to welcome Dr. Ron Epstein. Ron.
I'm very pleased to be here with all of you, and actually I'm quite overwhelmed with the response to the webinar. I first thought, kind of imagined that there might be 30 people online, and from what I understand, there were over 900 people signed up. My hope today is to talk about resilience and ways to promote it in healthcare. And before I start presenting any particular content, what I'd like you to do is first take a look at this photograph on the screen, and just think about what images it conjures up for you. This was actually taken during Hurricane Sandy. The things that many people find striking about it is just the force of nature, the force of waves, some concern about the integrity of the pier, and also the fact that the image, although it's a color image, appears almost as if it's in black and white, that the color is muted. Take a look at this image now, taken on the same beach storm, and kind of contemplate this person who is interacting in some way with the environment. He has a surfboard, appears to be walking into what many of us would view as frightening. And kind of going back to the previous picture, think about what days you've had in your work life that may have started out kind of looking like this, and possibly days in which you felt the kind of confidence and that is displayed by the person in the second photograph. I'd like to start out with several hypotheses about resilience in healthcare for clinicians. The first is that compassion for others is facilitated by compassion for oneself. That is that, and I think most major psychology and spiritual traditions would tend to echo that one needs to be able to express kindness towards oneself. The second hypothesis is that resilience is, sorry, I think I skipped a slide here, is that compassion requires resilience, that in order to face and be present with patients who are suffering, that we ourselves need some capacity to deal with that suffering and not crumble in the presence of it. The third is that this resilience is a capacity that can be grown, that it's not necessarily something that we're all born with, but rather something that we develop during childhood and adulthood. And the final hypothesis is that, the next hypothesis, sorry, is that well-being is about engagement, not withdrawal. We're not talking about when and where to take your next vacation, but rather how to achieve a state of balance, well-being, resilience within the work environment in which you're working. And then the final hypothesis is that mindfulness is a community activity. That is, that our efforts to become more self-aware, more resilient, and more present with our patients is not only contingent upon what we can do individually, but also what we can do collectively. The definition of resilience that I'd like to use is the ability of an individual to respond to stress in a healthy, adaptive way, such that personal goals are achieved at minimal and psychological and physical cost. And importantly, resilient individuals not only bounce back rapidly after challenges, but also grow stronger in the process. Now, why does this matter? Why might the public be interested in how distressed clinicians might be? Well, there's a whole body of research dating back to the early 1990s that correlate clinician distress with lower quality of technical care, riskier prescribing practices, more medication errors, lower patient adherence to treatment, more unsafe behaviors, lower patient satisfaction, and also factors within the clinician that might be subsumed under professionalism, erosion of altruism and empathy, unprofessional conduct, poor relationships with staff and patients, and also clinician distress is costly. It results in higher attrition and job turnover, and for those who are interested in the bottom line, higher recruitment costs. Our theory about clinician resilience is that it's directly related to the quality of care and quality of caring, and that these things are all interrelated. Tate Schoenfeld and his group at Mayo have done a variety of studies in which burnout was measured in clinicians. and found correlations between all three of these factors in medical students, residents, and practicing physicians. I want to say a word about burnout. Christina Maslach, who did the seminal work on burnout in professionals, describes it as having three components: emotional exhaustion, depersonalization, and low personal accomplishment. Depersonalization refers to treating patients as objects. The low personal accomplishment, no matter how hard I work, nothing improves. I think all of us can relate to these factors. Burnout has been described in other ways. Christina Maslach herself describes it as erosion of the soul, a deterioration of values, dignity, spirit, and will, a silent anguish of healers, a culture of endurance, a failure of adaptive reserve. So there's a continuum between burnout and resilience, between being withdrawn and engaged, between emotionally exhausted and feeling energized, between feeling that you're going through the motions and feeling that you're sticking to a mission, feeling that you're worn down or brittle, contrasted with the ability to bend and not break, cynicism as opposed to a capacity for positivity, being hypercritical as opposed to having a more light touch. And I think you can kind of go through the rest of these on the slide. I think we all feel that we're on the spectrum somewhere. Actually, at this point, I'd like to transition to the poll and give the mic over to Lynn.
Thank you so much, Ron. We'd like our audience to participate in the poll. How burned out do you feel? I'm going to read down the choices. Not at all. I'm feeling engaged with my work is the first choice. Occasionally, and I recover reasonably well, the second choice. Third choice, frequently, and I'm not coping as well as I'd like to. Number 4, significantly, burnout affects me daily, but I keep going. And 5, severely, I don't think I can go on like this. If you could put your votes in, we'll wait a moment while people get a chance to find their mouse interface. And we're looking good. All right. And just a few minutes more. Again, not at all. I'm fully engaged in my work is number 1. And number 5, severely. How burned out do you feel? I don't think I can go on like this. Great. Thank you. We've got 85% of our folks have voted. And the replies are 12%, not at all. I'm fully engaged with my work. How wonderful. 60% occasionally, and I recover reasonably. 20% frequently, and I'm not coping as well as I'd like to. Significantly, burnout affects me daily, but I keep going, 6%, and 1% severely. I don't think I can go on like this. Ron, would you like to comment?
Yeah, absolutely. So I'm sorry, can I have my next slide, please? Great. Thank you. So the okay. My apologies. So I think the results are a little bit better than what we have seen in surveys of practicing physicians and residents and students. And I guess that's heartening. Perhaps we have a more resilient crowd on the webinar than we find in general. And also, this informal poll was not using the full Maslach burnout inventory, which seems to show that a surprising percentage of practicing physicians endorse a significant degree of burnout, You can see that up to 76% of internal medicine residents in one program. A more recent study, about half of medical students. And among those students and residents, a year later, the same, about 50% of those same people are still reporting feeling burned out. Women are affected more than men. And burnout seems to peak in mid-career. It's unclear exactly why that's the case, whether it's because those who are the most burned out tend to leave practice earlier, or whether they develop some mechanisms for adaptability. And depending upon which of those three factors, emotional exhaustion, depersonalization, or low personal accomplishment you're looking at, they peak at a different point during career. So low personal accomplishment tends to be worst in medical students and interns, whereas this sense of emotional exhaustion tends to peak in mid-career. So I'd like to move to the next slide and consider what might affect burnout or what the causes of burnout might be. This would be slide 21. The first set of factors have to do with balance between work life and home life, balance between career and family. The second set of factors have to do with the work environment, whether you're in an environment that feels supportive, competitive, whether there are productivity pressures, demands, time, and this, in particular, this constellation of low control and high responsibility seems to be particularly toxic. There are individual psychological factors, feeling alienated from one's work, oneself, moral distress, having to do things that one doesn't believe in, and also developmental factors. How easily do you regulate your own affect? How in the face of stress, to what degree can you maintain your mental and emotional stability? Does your boat rock very much with each wave? And also capacity for knowing oneself and cultivating and observing self and self-monitoring. And then finally, physical factors as well, like sleep and pain and illness. On slide 22, I'd just like you to consider some values that we all go into medicine and things that we tend to value in excellent practitioners. Think about who you would want as a practice partner, who you would want as a resident in your residency program. Clearly someone who has a sense of service and altruism, clinical excellence, curative competence, knowledge, empathy, caring, and equanimity. But each of these qualities has a dark side, that people who are altruistic tend to overcommit, tend to deprive themselves, sometimes feel entitled. Those who aspire to excellence may be perfectionistic, feel invincible, may lead to hiding their errors. Those who feel competent may feel impotent on the one hand, or may actually feel that they're an imposter. They're putting on a show and they really don't believe in themselves. Physicians generally have a need for certainty and feel uncomfortable in the face of uncertainty. I did want to talk a little bit about the connection between empathy and personal distress. My interest in this was piqued by a survey that we did of our own students and residents that seemed to show that those who were the most empathic also reported the highest degree of emotional exhaustion. And I think that really speaks to an increased emphasis that we have in medical education on connecting with one's patients, but without a concomitant emphasis on how to become more resilient in the face of witnessing suffering and others' distress. Caring, the dark side could be neglecting oneself and family, and equanimity the dark side could be distancing or othering, saying this person is not like me, therefore I don't feel their pain, I don't feel close to them in some way. Resilience, on the other hand, is associated with the capacity for reframing, balance, gratitude, self-compassion, knowing one's limitations, knowing what's unknown, feeling more comfortable with uncertainty. Interestingly, compassionate action seems to be processed during using different neural pathways than just simply feeling and expressing empathy. That somehow engaging in action to improve the lot of someone else triggers the reward centers in one's own brain, so that the capacity to be resilient and be with someone who is in pain and then act in such a way as to relieve that suffering actually is, in a way, nurturing to the healer, him or herself. Resilience is also associated with self-care and also with engagement with work, not withdrawal. So you're probably all wondering what makes some people more resilient than others under extreme stress. And here, the literature is really insufficient in terms of the questions that we're dealing with in health professionals. Most of the work on resilience has to do with survivors of single event traumas that have a beginning, a middle, and an end. Someone who's a concentration camp survivor or a rape survivor, or people who do or don't get PTSD, etc. So we don't really know a lot about development of resilience under chronic stress. However, I assume that some of these factors are also at play. For example, the degree of stress inoculation, of being exposed to the right dose of stress so that one develops a greater sense of strength and confidence, a secure attachment style, a capacity for mentalization. Mentalization means the ability to see an emotion as an object, that is to say, I am feeling this, to kind of explore one's own emotions and to regulate one's own affect. Learned self-efficacy, and some practices of self-compassion and self-regard. There are also biochemical differences between people who are more and less resilient in terms of release of stress hormones, testosterone, as well as some brain-gut hormones like neuropeptide Y, serotonin, dopamine. And these are all associations. We can't really say that they're causative. But what we do know is that the expression of these hormones is socially mediated. That is, that the genetic expression of our responsiveness to stress is not a given. It's not something that we're born with, but has something to do with our own environment, the community that we're in, the organization that we work with, the family that supports us. Some work also done by Schoenefeld's group talks about career fit, the extent to which an individual is able to focus their effort on the aspects of work that they find most meaningful. They ask people what they like to do, what they find most engaging, most enjoyable, most important about their work. And those who whose career fit, who spent more than 20% of their time in an activity that they view as most meaningful, tended to be less burned out, whereas those who spent more than 20% or less than 20% of time in activities that they found meaningful tended to be more burned out. This is not rocket science, but still it's important to think in terms of yourself and those you work with, what factors are really under your control and which are not. When we teach about resilience to medical students and residents and practicing physicians in seminars and workshops that we offer, we talk about three kinds of reactions to stress and the ability to identify them. Unhealthy reactions, things that you really don't want to do and shouldn't be doing. Sometimes things that you can't keep yourself from doing. That might be withdrawal. It might be something like drinking. It might be disengaging from something that you really should be involved in. Survival skills are things that may help you get through a tough time, but may become destructive if they're habitual. These are things that you kind of do once, you feel okay about it, and then you're hoping that that doesn't become a habit, but it's something that gets you through the day but doesn't really cause particular harm. The third set of skill responses have to do with being more mindful, more resilient, more growth-oriented, experiences that actually help you grow as a person and develop as a professional. So about 15 years ago now, I started writing about mindfulness in medicine, and gradually people started challenging me, well, what are you going to do about trying to promote this ability to be reflective, self-observant, to be resilient, to promote one's own well-being in the interest of providing better care to patients and better relationships with our colleagues. And there are really two levels on which we can think about this. One is organizational approaches or team approaches. And within that, there are studies that simply report about what happens if you just simply measure this. That if you consider clinician wellness a healthcare quality indicator, and in some health systems in the UK, they're actually doing this. They measure clinician wellness in the same way that we measure other indices of quality in healthcare. It allows monitoring. It also communicates institutional values by drawing attention to commitment and interest in the healthcare workforce. And if the measures are brief, they're reliable, actionable, and followed by action, people actually do participate. So this was in BMJ in 2009. Organizational approaches have been going on at least since the 80s. You'll see in the second entry here, there was a stress management program in 22 hospitals that led to lower medical errors and malpractice suits. One wonders why other health systems didn't really pick up on this to the degree that they otherwise might. Why it's taken 25 years for people to look at this research again. Even giving clinicians more control over their work environment, about the office design, staffing, hours, etc. Just even doing that little bit decreased emotional exhaustion and burnout in two different studies in two different contexts. Canada has been a bit ahead of the U.S. in terms of developing programs that not only intend to treat impaired physicians, but also recognize physicians who are at risk. For example, in Alberta, physicians who practice in isolated rural areas are identified as potentially at risk, and these physicians undergo a kind of practice audit. So they're visited by a team whose intention is to try to understand what the stresses are in the practice and to optimize the care that that clinician can provide. There are remediation programs for physicians who are actually impaired, but more importantly, there are programs that use a variety of kinds of assessments and resources to help those physicians who might become so. I want to mention, it's not on the slide here, but just this past month, a program, there was a publication in JAMA Internal Medicine about a program at Mayo where people in the Department of Internal Medicine physicians in the Department of Internal Medicine were randomized to a program in which they had an hour freed up from clinical time every 2 weeks to engage in a group discussion about various aspects of stress in the workplace. And these were a discussion format loosely facilitated by a trained facilitator, and they met every other week for 9 months. At the end of that program, there were significant decreases in one aspect of burnout, and also some increase in job satisfaction. They measured a number of other things that didn't seem to pan out, but it really is an example of a program that was really undertaken on an institutional basis. Here in Rochester, as well as at Monash in Australia, and several other programs, have required programs for medical students that address burnout and self-awareness. We frame the programs here in Rochester in terms of what we call mindful practice. At Monash, it's somewhat similar, and there are programs in other institutions as well. In the U.S., about half of medical schools have some kind of elective that addresses mindfulness, well-being, or resilience, but there aren't a lot of, the majority of medical schools still don't have required programs. And part of the challenge here is that there are many programs out there, and I often am asked to speak at them, but they often don't publish what they're doing. So it's hard to know the extent of I should say parenthetically that this idea has really been embraced in industry. At Google, there's a program called Search Inside Yourself. What do people at Google do? They search. But here, it's not searching on a computer, but trying to understand oneself as a way to improve one's well-being, productivity, etc. And there are lots of other corporations that have embraced similar programs for their employees. So, so here's a question: is mindfulness one answer? I know mindfulness is the vogue. In February, Time magazine had the cover lead article about mindfulness in American society. Today came out at the Washington Post, another article. They're kind of popping up all over the place. And I'll just say it's one approach that our group here has pioneered, but I think we have to think about many ways of trying to deal with this issue of resilience in healthcare. Mindful practice I define as moment-to-moment purposeful awareness of one's own mental and physical processes during everyday work with the goal of practicing with clarity and compassion. This is not sitting on a cushion at a retreat center or doing yoga poses on the weekend. Mindful practice is really about one's way of engaging with the workplace in a way that fosters awareness of oneself and others and the cultivation of resilience. So our hypothesis here is that mindful practice may have a direct effect on resilience, well-being, quality of care and safety, and quality of caring and compassion. And I'm going to present this as kind of as a work in progress, as a hypothesis. There are correlations between being more mindful and being more attentive, especially to disruptions in routine. There are studies of surgeons in the operating room in which they identify moments when they slow down. And Carolyn Moulton in Toronto has written about surgeons who slow down when they should and surgeons who don't. Those who don't slow down are the ones who keep the music running and talking about their golf game. Those who do slow down are the ones who, for whatever reason, notice that there's a speed bump coming, slow down, pay a different kind of attention to their work. Mindfulness helps develop the resilience in order to be more present, more caring, and more compassionate with patients as well as with colleagues. So mindful practice has three components. One is intention, one's sense of purpose, one's vision and direction. One's attention, what one notices, intentionally pays attention to, considers relevant or ignores. And finally, attitude, how you construct the world, your perspectives, judgments, your degree of flexibility, curiosity, and presence. So thinking back to those photographs at the beginning of the presentation, that surfer who's kind of examining the waves with curiosity, with engagement, trying to figure out how to deal with this as a challenge, as opposed to the peer that's standing there waiting to be knocked down by the waves. I want to actually take a moment here to just remind you that I am a clinician. I'm not living in a fantasy world, and that these issues of facing the waves really is something that, for me as a clinician, is a challenge every day, as it is probably for most of you. That these qualities of mindfulness are not a goal, but a process. So that when developing these habits of mind of being observant of the expected as well as the unexpected, that's something that one cultivates, one works on, one becomes aware of. I think we all feel comfortable with the expected, and developing some comfort with chaos and differentness is what we're talking about. Critical curiosity, developing a cognitive flexibility and openness, a capacity for self-questioning. Beginner's mind, holding contradictory truths simultaneously. This patient is someone who's whining. This patient is someone who's in pain. To try to hold these two images of this same person, this same situation in one's mind simultaneously, not saying that one is true or one is necessarily false. Seeing information as novel. You've seen 10 people with the flu today, and someone else comes in with a fever and a cough and feeling achy. This might be the person who's bacteremic. You don't know. Seeing facts as conditional. And I think I've talked a little bit about mental stability. I don't know how many of you have ever been in a kayak, but when you buy a kayak, they talk about primary and secondary stability. Primary stability is how tippy the kayak feels and also how maneuverable the kayak is. So if you're a good kayaker, you like a kayak with a lot of primary instability. You want a kayak that's supple, that moves, that kind of moves around the waves and around obstacles more easily. But you want a kayak that has a lot of secondary stability. So primary instability and secondary stability. Secondary stability refers to how easy it is to capsize. Okay, so we don't want to capsize. We need to know ourselves well enough so we can engage, we can be supple, we can be emotionally present, we can lower our level of reactivity to the point that we can engage even when we're feeling anxious or bored or overwhelmed. The radical thought here is that these are things that can actually be cultivated. So here, when I was beginning to develop programs on mindful practice for clinicians, felt a little stuck in terms of what I learned in my own medical training, so I went back to things that I had learned previously before I went to medicine. And my first career was in music, and just thinking about practice. You know, what are these things you can practice? You can actually practice being emotionally expressive. You can practice performing in front of an audience. You can practice tolerating anxiety and still producing something of beauty that communicates to an audience. And similarly, I had spent some time when I was younger at a Zen monastery, and learning meditation practice is another form of practice in which one practices observing the content and process of one's own thoughts and feelings, and then an ability to not react to them immediately, but respond to them in a more thoughtful and mindful way. So in a lot of our programs, we invite people to do some kind of contemplative practice and start slowly, 2 minutes twice a day daily, increase as tolerated. Informal practice, find a moment to stop and breathe. As a clinician, from one room to the next, appointments are 15 minutes, I move quickly. But when my hand touches the doorknob, I take a second to just take a breath and mentally set behind me that which has happened with the patients before the patient I'm about to see, to clear my mind to be present and available to the patient who is next on my schedule. So sometimes we give people assignments to find brief opportunities during the day to stop briefly, take a breath, and just pay attention to the moment. That's it. Call that an informal practice. So reflective questions. Now, these are questions that I propose that clinicians maybe make a habit of asking ourselves. You know, what's new or unique about this situation? What am I assuming that might not be true? There's now a whole movement led largely by Pat Crosscarry and others about diagnostic error, in which introduction of some of these questions into one's clinical thinking can help broaden perspectives when necessary. You can just change these questions around to ask medical students on rounds. You know, what are you assuming about this patient that might not be true? Are there things that you're presenting as fact that might not be quite so clear? What would a trusted peer say about the way I manage this situation? So the another way of becoming aware is just through discussion. So we'll ask students to pair off with a partner and identify a stressful event, and then think about what the earliest warning signs of stress that they felt. Was it a knot in their stomach? Was it the beginnings of a headache? Was it not feeling hungry? Was it that their handwriting got worse? Was it that they tripped over their feet? What was this a feeling, an emotional feeling? Was it something more physical? Was it a thought? Were they thinking that they were not negative thought about themselves, and to try to identify those early warning signs of stress before they grow into later warning signs of stress. So developing this discernment, this ability to know oneself more intimately, if you will. So we ask, and then we often ask people to pair off in groups or in groups of 3, and to use narratives, to write about a time when they had a particularly meaningful experience, or a particularly distressing experience, or a particularly an experience in which they made an error, or an experience in which they felt attracted to a patient. Whatever it is that may have some affective content to it, and to take some time to write it down. Now, why write it down? Because it actually helps put people back in that setting, in that scenario. And then to share the narratives with each other in particular ways, to focus on both being a reflective storyteller as well as a reflective listener. By that meaning being attentive, to ask questions to help your partner clarify and provide details, but to avoid talking about one's own experiences, even though they might seem relevant, the ability to really focus on the other in a mindful and present way. Appreciative inquiry refers to asking questions that help strengthen a system's capacity to apprehend, anticipate, and heighten positive potential. So an example of an appreciative inquiry interview that people might do with one another is to focus on a difficult moment in which you were at your best, to describe that event in detail, and then reflect on how those attributes might be applied in future situations. And both with the narrative and appreciative inquiry exercises, there's the possibility of applying it to a variety of themes in clinical practice: perceptual biases, meaningful experiences, surprises, burnout, dismissing patients, teamwork, self-care, end-of-life care, grief and loss in clinicians, conflict, feeling attracted to patients, etc. So all of these really can be applied in using either of those techniques. And I think part of the goal is to develop this self-awareness in which one can realize or become aware of when you're outside of this optimum work zone box, when your arousal level is too high, when your hedonic tone, again, whether you're feeling good about a situation, whether it's pleasant or unpleasant, to expand that box so that you can actually, so first of all, realize when you're in the box and out of the box. If you're out of the box, to recruit help, to recognize that you may need to look something up, that you might need to take a break, but also to develop this mental muscle that we all have to expand that optimum work zone through mindfulness-related exercises, through discussion, through narrative, to try to understand the domains in which you can be most effective. So we tried piloting this approach, using all of the approaches that I just mentioned, with a group of 70 primary care physicians in 2007, 2008. We met in 2 cohorts, one cohort of 30 and one cohort of 40. Each group met for 8 weeks, every week, 2.5 hours a week, and then for a full-day retreat, and then 2.5 hours a month for a year. We intentionally did this. It was intensive, but we really wanted to see if we could make a dent in this growing problem of burnout, empathic failure, and distress in clinicians. And starting out, this was a fairly highly distressed group of primary care physicians. Their baseline burnout scores were quite high. We also measured psychological distress using another scale, and also measured empathy, as well as their orientation towards care, whether they tended to be more or less psychologically oriented. Finally, we measured their personality because we thought that their personality might actually be a moderator. That is, it might influence their ability to respond to this kind of a program. And parenthetically, about 20 or 25% of the primary care workforce in Rochester participated in a program like this, although not necessarily as long. I'm not going to present all of the data slides, And this is just a mediation analysis here. But I just wanted to point out that we showed major changes in physicians' burnout, their mood disturbance, their empathy, and also their psychosocial orientation. And the factors listed here are those that appear to be directly correlated by changes in physician mindfulness. These are all self-report. The thing that surprised us was that personality was not a moderator at all, but in fact personality appeared to change during this intervention, that physicians became more attentive in general, and also felt that their boat wasn't able to be rocked quite as much. They had developed more of this secondary stability in the face of stress. And we did a qualitative study afterwards asking physicians really what was it that really made the difference for them. And this was between 3 and 12 months after completing the workshop. And the first and probably the most important had to do with building a sense of community, that just simply gathering together into a meeting place where people were invited to reflect more deeply, just that is tremendous, and it happened over a year's time. It takes time for these stories to unfold, and that it was a real engine for developing community and fostering introspection. Becoming more present. This is a before and after. Before, I will spend that extra time with my patients if they need it, but in some ways that was kind of sucking me dry. Now, it's not that I don't empathize with them anymore, but I feel it's just okay to listen and be present with them. And I think that in some ways that helps them more. Becoming more honest. One of the things that comes out of this is when you establish a practice of thinking more honestly, thinking more clearly, speaking more honestly, that definitely leaks out into your work every day. You can read the rest, but he goes on to say it certainly made it more immediate and easy to do in his practice. Originally, I was doing the course for stress reduction. Then as time went on, I'm learning how to communicate with myself as much as anybody else. I sort of gave myself permission to start thinking. And a lot of the physicians felt some sense of guilt that they were taking this time to better themselves as opposed to spending time at work or with family. But if you ask them, where does this come from? They said, well, it was just me. And there were many stories of physicians saying, well, my wife said I really need it, and that's why I'm here. But it's this reluctance to take action to care for oneself was really an important theme, and it was really the group that enabled this group of physicians, the group spirit of the community that was formed, that enabled this group of physicians to enact this. So just in summary, this is not the only approach to trying to become more resilient, but I think that as approaches are being developed in industry and also other healthcare settings, these seem to be the important components. That is some way of developing community, some way of sharing stories, and some way of introspecting, not in a way of just simply talking about one's thoughts and feelings, but developing a practice whereby one actually learns how to regulate one's own level of reactivity. There have been many studies in non-physician populations that show that this self-regulation can be learned at any age. We have programs for nursing home residents on mindfulness locally, as well as for children in elementary school. So I think these are learnable capacities and increasingly valued in a variety of settings. I also want to emphasize that we can't do this alone, and those of you who are in leadership positions can take this as an opportunity and a challenge to think about how you want to nurture, sustain, and grow the workforces that are under your charge, the clinicians, staff, and other people who work as part of your team in order to make healthcare better for patients and their families. This final slide, when you're looking at people who seem to have got it all, the arrow on the left is what it looks like on the outside. From our own perspective with the work that we're doing, it's much more complicated than that. finding appropriate language to talk about resilience, well-being, self-care, mindfulness, attentiveness, presence. All of those things really carry a lot of social meaning, and so language is particularly important. I'm going to turn the program over to Lynn at this point for some questions and answers. And again, I thank you all for being here and look forward to some discussion.
Excellent. Thank you, Ron. I'm sure our audience joins me in thanking you, Dr. Epstein, for sharing this important work with us. A reminder to our audience, if you have a question you'd like to submit, you may still do so. Just type your question into the questions pane on the right side of your screen, and we'll answer as many as we can in the time that we have left. I actually have some questions already, so I'm just going to start, Ron. Could you comment on the burnout statistics? Is this the U.S. sample, or was it done with international audiences as well, or participants as well?
The burnout statistics we have are just from the U.S., I believe, but I know that there are people in Europe and Canada doing work. The ones that I showed, though, are most robust. Schoenefeld is really his group has really done most of this work, and it's they have increasingly large sample sizes within the U.S., so I think they're fairly representative.
And would you like to comment on what your expectations would be if you did these surveys around the world?
Interesting. I'm next week going to Tokyo and Osaka to give exactly these same talks, so I'll let you know about Japan, but I've been assured by my hosts there that clinician burnout is a serious issue. I've done work in Spain and the UK and Australia, and I really haven't seen any qualitative differences in terms of the type of stressors that people have. I think medicine is intrinsically stressful, and that the efforts to deal with burnout and resilience are spotty in all of these settings. There isn't a national, in the UK there have been some important efforts, but I don't think it's become nationalized in that way.
Thank you. Very helpful. Second question, what information do you have regarding the role of prayer, spirituality, belief in God in either frequency of burnout or the capacity for resilience?
That's a really interesting question, because here you're kind of treading on not just the religious and spiritual belief system, but also the way one interacts with that particular belief system. People frequently will find some solace in having some concept of a higher power and the ability to kind of share their distress with that. But if those beliefs are held too rigidly, then people tend to crumble more when they're under unexpected stressors. So I think it's kind of this double-edged sword that we're just beginning to unravel. I think spirituality for most people has a positive valence, but it doesn't always seem to pan out in terms of adaptability to distress. So I think the jury is still out, an important area of research.
Thank you. Excellent. Let's see. How do you relate the happiness literature to the resilience findings?
Well, it depends which happiness literature you're looking at. I think that the literature that I'm familiar with, well, actually, there are two literatures, I guess I would say. One body of literature basically is now saying that the more you have, the happier you are. They've done cross-sectional surveys of people who are multi-millionaires, billionaires, and people who are in poverty, and seem to be reporting some kind of linear relationship. I'm not quite sure it's quite so simple. Another stream within the happiness literature has to do with one's own sense of autonomy, of relatedness, and of competence, subsumed under self-determination theory. And there are a number of other theories that kind of talk about these personal qualities that really have to do with the way that one the attitudes one takes in relating to the world. That latter literature really deals with happiness as something that one can cultivate in oneself, that through finding meaning, through finding connection, and through developing the capacity for self-forgiveness and self-compassion. That latter literature gives me a bit more hope because it means that regardless of the situation you're in, that there's something that you can do as an individual to, in a way, change your relationship to the world that you live in. But I don't want to be Pollyannish about this because I think there are really important contextual factors. This toxic combination of high responsibility and low control, in particular, is one that even in people who are otherwise tending towards happiness can really undermine their efforts.
Very helpful, Ron. There's time for just one more question. Our final question is, do you think some of these findings have implications for family caregivers as well?
Interesting that you should ask. Because I'm currently doing a research study on patients with advanced cancer, their physicians, and their family caregivers, exploring some of these same issues of resilience. And I think, you know, this talk you could, and actually I have, morphed into a talk for educators and a talk for parents and a talk for family caregivers. I think a lot of the things here are really generic human capacities and human skills that can be cultivated. There's nothing that's intrinsic about physicians that makes this kind of these kinds of issues unique in that way. I think that the reason that it's important to have programs just for physicians or just for health professionals or healthcare teams is it really has to do with language and focus and the specific kinds of stressors that we face. Families will face the death of another individual very occasionally, we hope, in most circumstances, but physicians face death every single day. And so a focus on how one deals with grieving, end-of-life care, and errors really takes on a different kind of valence. So it's really the language that you use and where you choose to shine the light on, but the same activities of developing an observing self, becoming curious, developing a beginner's mind, and being more present, I think really apply to many things in life, not just healthcare.
Excellent, Ron. Thank you. Your considered answers are wonderful and greatly appreciated. I'm afraid we've come to the end of our program. Please notice if you asked a question and that we were unable to get to, and I have quite a few here, those questions will be sent to our speaker, who will do his best to get a response to you directly. I'd like, again, to thank Dr. Epstein for sharing his expertise and insights with us, as well as everyone in the audience for setting aside time in your busy day to participate. This concludes today's program. We'd very much appreciate your taking a moment to complete the electronic survey, which we'll be sending upon exiting today's program. And we greatly value your input and thank you for your commitment to compassionate healthcare. We hope that you'll join us for upcoming programs in the Schwartz Center for Compassionate Care webinar series, Transforming Moral Distress into Compassionate Action, on May 13th, and The Space Between Self-Esteem and Self-Compassion, October 9th. You can visit theschwartzcenter.org for more details and look for our webinar email invitations. Commit to Compassion is we'd also welcome you to join our Commit to Compassion call to action. To foster a more compassionate healthcare system, we're calling on all who believe in the importance of compassion and compassionate healthcare to support and endorse the following set of commitments, which we believe would go a long way toward making compassion a priority in our healthcare system. You can commit to compassion on our website. Thank you all and have a great day.